very good evening, everyone. Teremo India Skill Lab is pleased to welcome you all to our Fireside Chat series. Today in-house, we discuss about a very novel technique, which is the prostatic artery embolization. This technique is performed by interventional radiologists. How essential it is in delivering the minimally invasive options for your patients, who is an ideal patient to undergo this technique, and what all must you know to advise your patient this treatment option. Let us hear directly from our experts today. It is my honor to welcome Dr. Manish Kumar Yadav, sir, consultant neurovascular interventional radiologist at 𝐏𝐵𝐶 Trivandrum, and Dr. Avinash Kumar, sir, senior consultant diagnostic and interventional radiologist at the 𝐏𝐫𝐫𝐚𝐧𝐬𝐼 Medanta Hospitals, Patna. I would request the audiences to please feel free to share their queries with us in the chat box. We'll be glad to take them up towards the end of today's discussion. So without further ado, I welcome our speakers once again, and over to you, sir, for taking us through this very insightful discussion today.
Thank you, Dr. Shruti. I think let's start this wonderful discussion on prostatic artery embolization. As we all know, this is a very brand new kind of intervention radiology procedure. I mean, the first case was actually initially done was in somewhere around 2000. It was hardly around 20 years back we have started this procedure, and it has changed dramatically the treatment protocol of our so many old patients which are suffering from benign prostatic hyperplasia, which cannot undergo surgery due to various reasons because they are not fit due to either they are having some comorbid conditions, so they are not surgically fit, or they are not willing to accept the surgically related or medicine related side effects. So in that case, there are other so many alternative surgical options are also there. But this this prostatic artery embolization has come a long way to give an alternate solution to such a patient, so that we can offer them slightly better treatment protocol. So today we'll be discussing, me and Dr. Manish will be discussing the various aspects of prostatic artery embolization and how we can offer this treatment to our various group of patients. And we'll be touching upon in the layman term what exactly is this, so that people who want to listen and they are listening this term terminology first time in their life, they can understand what exactly is this, and they can come straight to interventional radiology for such procedures. We'll be also discussing a bit of technical aspects of this prostatic artery embolization, so that our colleagues from the medicine fraternity like urologists, physicians, and radiology and interventional radiologist colleagues, they can also get benefited from this discussion. So initially, to start with, Dr. Manish, what exactly is this prostatic artery embolization?
So basically, the prostatic artery embolization was being performed before, but indications were different. When patient used to come with hematuria and nothing else used to work, then some patients underwent embolization. And what was found that the previous embolizations were done for basically hematuria to control bleeding. And when these patients were studied later, what they found was many of these who had prostatic symptoms, basically lower urinary tract symptoms because of hyperplasia, they found a significant relief after this procedure. So although it started not intended to relieve, but they found that it provided good relief, and that sets the ball rolling. And there was further research, and then a lot of trials, and we have a trial which has compared this procedure to a sham procedure, and now it is kind of established, and it is now part of the NICE guidelines, where we go ahead and embolize the prostatic artery. So basically, the procedure is done through a artery in the wrist or in the groin. Today, we are doing more and more procedure through the wrist because it is very comfortable to the patient. Then we localize the prostatic arteries. Usually, there are two or more arteries on either side of the pelvis, which supplies the prostate gland. And then we go and embolize these arteries with small either gel foam or synthetic particles. And once the blood supply is stopped, what is seen is over a period of time, these patients find significant relief of their symptoms. So that's what, in short, is prostatic artery embolization.
And suppose if I'm asking in terms of a layman person who's listening this thing, I mean, which patient can be offered this kind of a procedure, and why not a surgical option? And then how can we say that I mean, you are the right candidate for this kind of a procedure? How do we select this kind of a patients?
That's a good question. Basically, anybody who has after 50 years of age, they have some amount of benign hypertrophy of benign hyperplasia of the prostate, and then although all may not be symptomatic, so gradually these patients, as they become older and older, they sometimes become symptomatic, and after 80 years of age, majority of the patients are symptomatic. Basically, the symptoms in terms of there is irritative symptoms at the filling phase of the bladder. So when the bladder is filled, they may find it difficult to control. They may find dysuria, and then when they go to pass urine, they find the stream to be weak. That is the emptying phase of the bladder. They find the stream to be weak. It may take time to start urinating, and then after they finish urinating, they have a sensation of incomplete emptying, and then many times it is difficult for them to hold on urine, and many times it leads to recurrent infection because there is significant urine which remains in the bladder even after they passing. A lot of patients suffer from increased micturition at night. So sometimes they have to get up 3 to 4 times at night to go to the bathroom. So it kind of affects their sleep. So broadly, these are the symptoms. And then the first line therapy is definitely medicines, which try and control the symptoms. This procedure is for those patients who are not, they do not find adequate relief with in their symptoms with medications. When the medications are given for reasonable amount of time, and then there are some patients who have urinary retention, who are catheter dependent. Again, somebody with that will be a candidate. When we started many years back, most patients who were not surgical candidates, so traditionally all these patients were being treated by surgery, mostly TURP, transurethral resection of prostate. But then a lot of patients who had urinary symptoms, they were not being controlled with medication, but they were not surgical candidates. So they didn't had any other treatment option at that point in time, and a lot of them were on catheter. Majority would be kind of cardiac patients. They would be a large prostate, like more than 100 grams prostate, where they will be on antiplatelets or anticoagulation there, which cannot be discontinued without any significant risk for the surgery. So we used to do a lot of those patients in those days, but now the things are changing and the awareness is spreading, and then we see a lot of patients coming early to us with these symptoms which are not managed with medically. So
Yeah, actually, basically, what you said was right. Initially, there's so many patients who, for their milder symptoms, they probably don't require any treatment. But for the moderate and the severe, obviously, the first line of, as you mentioned, the first line of treatment is always the medical management. But these medical managements are not short of multiple side effects. Like a patient do present with some side effects like erectile dysfunction and retrograde ejaculation. Similarly, even the TERP was not, is also associated with a lot of side effects. Some patients do land up with sphincter injuries and those kind of side effects, and they keep on having the dribbling of urine throughout their life, and sometimes they will be dependent on the diapers and everything. So, I mean, these kind of patients who either are not fit for surgery or sometimes they are not willing to take the side effect risk which comes along with the medical or surgical management can definitely be taken up with this kind of a thing. So, I mean, what kind of a basic pre-procedure evaluation do we require for taking up such cases for prostatic artery embolization?
So before as we evaluate a patient for the procedure, we look at their medications, what they're on, and then we look at their PSA levels. If they are elevated, then we need to rule out a kind of malignancy either by a biopsy. We have to talk about that, whether they need a biopsy, or sometimes we do an MRI to just be sure that it's not some malignancy which we are dealing with. Once we rule out that, and then we do the basic blood workup, and then we also do urine culture, basically to rule out any ongoing urinary tract infection. As we know, since we are going to embolize and devascularize the prostate gland, one of the possible complication is a infection happening. So we don't want to do the procedure when there is active infection. So we do a urine culture. Then we also do kind of pelvic angiogram, CT angiogram, just to make sure how the iliac arteries are, how the prostatic arteries are, and how difficult or easy the case is going to be.
Yeah,
We also sometimes do kind of uroflowmetry just to make sure that we are dealing with BPH symptoms only, and not some kind of detrusor dysfunction or some other kind of pathology where results may not be as good as we want it to be.
yeah. I mean, that's what you said it right. I mean, most of the time we generally do not do the more invasive like urodynamic studies and all. But wherever we suspect that that this is not obstructive features, but these are irritative features because of the overactive or underactive bladder. In that case, we have to subject the patient to undergo a urodynamic study, which is much more invasive. So that if urodynamic study is positive, and if we come across that patient is having irritative kind of a symptom, then we clearly know that these kind of a patient will not get benefited from prostatic artery embolization. So we exclude those patients for that, for prostatic artery embolization. And so generally we do not. So in your opinion, we do not do. I mean, do you routinely do uroflowmetry for all your cases which you take up for prostatic artery embolization, or where you suspect that there could be some red flags where the symptoms are not fitting in a BPH syndrome?
Yeah, absolutely. What you said is absolutely, I agree with. Is we don't do in all patients, but whenever we suspect that there could be something else also along with the BPH, then we do get the uroflowmetry done to be sure that the patient is going to be benefited by the procedure.
Yeah, so, and so the other question will be that who does this prostatic artery embolization? Urologists are doing it, or surgeons are doing it, or radiologists are doing it, interventional radiologists. So who does this? What exactly do we do in this? I mean, we'll be touching a bit of technical aspect, and if I may add, what will be the approximate cost? Because the first thing the patient will ask, if not TERT, and then what will be the approximate cost? Because this is the myth that the intervention radiology procedures will be very costly. So can patient bear the cost? And if you can tell us what will be the approximate cost of this procedure in India at least?
So, to answer your first part of the question, so basically, usually we admit the patient the same day morning or a night prior. We start the antibiotics in the prophylactic doses if they are not having any UTI. If they have a UTI, they receive antibiotics prior to the procedure so that we manage the infection. And then the procedure is done under local anesthesia, so there is no general anesthesia involved. Yeah, we do it most of our patients today through the artery in the wrist. So basically, we take a small puncture in the artery in the wrist. We pass a catheter. These are small tubes which reach the internal iliac artery. We do the angiograms from there, just like any cardiac or cerebral angiograms. Then, once we identify the prostatic artery, we take smaller micro catheters through that main catheter, and we go into each of these prostatic arteries. And then, once we are sure that we are in the prostatic artery and there is no other organ which is going to get these particles. We start injecting these particles. What we commonly use in India is PVA particles or embospheres, which are synthetic uh, uh, gelatin or acrylic particles. And then once we finish the procedure on one side, we go to the other side, embolize again. We make sure that we are embolizing the entire prostate, both half, because that gives the best result. Even if we are able to embolize one side because of some technical difficulty, still they can have good results. Once we embolize, then the procedure is absolutely painless. So none of the patients have any kind of pain during or immediately after the procedure. Some patients, maybe over next few days or a couple of weeks, they can have some kind of irritation in their lower abdomen, but that is fairly not very severe and usually responds to urinary analgesics. And then we discharge them after 4 to 6 hours or the next day. And then if they are on catheter dependent, then we typically send them with a catheter and then call them after a week. And that's when we try and remove the catheter and see if they can pass the urine. And once they're catheter free, then they're good to go. In case they fail their first trial without catheter, we retry after a week and see. Most of the patients, they get catheter free at the first trial. Those who are not on catheter dependent, they start getting this symptom relief around a week later, and then they report significant improvement in their symptoms a week from the procedure. The cost of the procedure at our center, it comes around 1 lakh rupees, which is almost comparable to a TURP at our center.
That's an important point. I just wanted to add on these things, Dr. Manish, what you want to tell. That I mean, there must be something baseline that we compare now. Suppose we have done the prostatic artery embolization. There's something called as the international prostatic
Mhm.
symptom score, which we give the patient to rate their LUTS symptoms, and then we again give them at the end of the procedure, probably after 2 to 3 days, and see whether they have got benefited or not. So, do you regularly ask the patient to fill up this thing, or any kind of a score thing that you ask the patient to fill up, so that they can you can have a comparison there, so that whether the patient has really got benefited or not? Or
Yes. So we routinely do this IPSS scoring system is basically a questionnaire which we can give to the patient, or we can, as we are taking the history, we can judge it how much it is and then do the scoring. Basically, to know how bad the symptoms are before the procedure, and then repeat it when they come for follow up in the OPD a week later after the procedure, and see how they are doing. Successful procedure means definitely they'll have the score coming down by more than 25%. And then we also do the quality of life index scoring because of the prostate. And then that also most of the time shows significant improvement. So these two scoring systems are kind of baseline, which we should be done in all patients. Especially this procedure is, we can say, in its infancy. So when we are dealing with the early procedure, we should be more careful and try and document our results so
yes,
that we can compare.
yeah, this gives an objectivity to the whole procedure, that that initially the IPSS score was this, and after the procedure, probably in a matter of 5 to 6 days, the IPSS score has definitely improved. So this gives the feedback to the radiologist or intervention radiologist who have done the procedure, as well as the feedback to the patient. Obviously, they must be having their subjective relief, but this objectify the whole thing, and this gives us the proof that prostatic artery embolization is a wonderful procedure in such cases. So, what all side effects can we expect?
Basically, one possible complications as per literature is non-target embolization. So, how we mitigate this side effect is, or this complication is being more careful. We look at the CT angiogram beforehand to be sure which are the probable sites from where the uterine artery is arising. If there are any abnormal arterial origins, which we need to interrogate at the time of angiogram, and then use of cone beam CT is particularly important in this to be sure that we are embolizing the prostatic artery. And then if you don't have cone beam CT, then we do multiple projections. Sometimes we go almost lateral to be sure that we are not embolizing the rectal arteries, and it's the supply is limited to the prostate. So that significantly reduces this complication. Another complication as per literature is the prostatic abscess formation. As I said, we do the urine culture in all patients before we go ahead and we treat UTI if at all it is there. And we also cover the patients who, even if they don't have UTI, with antibiotic for 7 days. So that pretty much takes care of the infection part of it. Some people may have some, as I said, some irritative symptoms for a week or two, which are kind of self-limiting with urinary analgesics, and they usually do not require any additional treatment. Pain is not a very common side effect. If at all, if anything is there, it responds very well to analgesics. So that's not a kind of worrying symptom.
Okay. So basically, side effects occur because of non-target embolization. We
Yeah.
have to make sure
Yeah.
that that we are not embolizing the small branch which is supplying the rectum as well as the penile. Okay.
Yeah.
So because these patients will land up with slightly severe complications. So how do you give the suppose the patient is on catheter. So when do you ask them to take a catheter trial? I mean, ask them to remove it or clamp it. After how many days you advise patient to take this trial so that they can make sure that they are passing urine well or not.
So basically, at the first visit, at 1 week, we try the first trial without catheter. So we take out the catheter. We call them in the morning, just ask them to. We take out the catheter and then ask them to drink some water and wait around till they pass urine. And once they pass urine, they are good to go home. In case they are not able to pass, then we recatheterize them and send them back and call them after a week or two to retry the trial without catheter. But we had patients who removed who got their catheter removed before this 1 week, and they didn't had any problems also. So, but anyway, we try to keep it up to a week, the catheter, so that all the edema and the inflammatory thing settles down before we go ahead with the trial of a trial without catheter.
Do we have to do a follow-up PSA or Euroflowmetry evaluation in such cases after prostatic artery embolization?
Once we do pre-procedure evaluation, it's not necessary. As we said, the uroflowmetry may be an optional thing before procedure. So after procedure, we do not do. We do get the prostatic sizes and the post-void residual urine and the prostatic volume around 3 months, 3 months, 6 months, and a year later for comparison and to see how they are doing with respect to a kind of objective criteria to see that the procedure is working or not. But shrinkage of the prostate will take time. It will not be immediate. At least mathematically or by ultrasound wise, once we see the volumes coming down after some time, but the symptom relief will be much more earlier before we actually see any prostate
That's
shrinkage.
right. So, that's what I wanted to add in that. In such cases, when you do follow-up, the follow-up is basically depends upon the relief from the patient side. Patient will come back to us and tell us, that they are feeling better, they're feeling better, the urine stream has improved. So this is not a cancer. So obviously we are treating something to improve the quality of life for such patients. Even if we find out, that The prostatic size has not reduced that much, but the clinical, the clinical findings have improved that much. That's all we want to attain. If the patient has improved clinically, and that's the best part, we do not go and chase around the exact 50% or 60% shrinkage of the prostatic size. So that's why there is no fixed protocol that should we go ahead and do a USG or a MRI in a follow-up, and when should we do that? There's no fixed criteria for a follow-up. Generally, I mean, as you mentioned, we see it in a 1 week time, or after that, to 3 months time, probably 6 months or 12 months. But there is no guidelines regarding that. When should we follow up such patient, and with what should we follow up such patient? So we just give them a questionnaire again and look for an IPHS score which has improved or not, or should we go ahead and do some cross-sectional imaging to document that the prostatic size improved? Unless the patient tells you that the symptoms has not improved, probably then there is a role for more invasive or some cross-sectional imaging to see what has gone wrong. Okay, how, I mean, the urologist will tell us, is it comparable to other surgical options for BPH? Like, TURP is a well-established, as you all know, the TURP is a well-established surgical option for BPH. It had been there much more, I mean, earlier days in the PA. PA is in such a nascent phase. So how do we convince our patients, that how do we convince our urologists that the PA can be done in such cases when they can go ahead and do a PA? Patients will also ask the same thing that I've been advised a TURP, and you are saying the PA would be helpful in that case. Obviously, the other criteria are there that where they are not surgically fit. But how do we compare that surgical options like TURP with PA?
So, as you said, the TURP has been there for many years, and it's a well-established procedure, and it is the gold standard against which this results from this procedure is compared with. So, there's no doubt TURP is there, and it has been there, and it is proven. Of course, there are some challenges with TURP, especially in larger glands, where TURP alone may not be good enough, especially once the prostate size crosses 100 grams. But there are other surgical options, including open prostatectomy. And as I discussed, we started our procedures with high risk patients, those who were not at all a candidate for TURP or undergoing any form of anesthesia. Then there were some patients who were on anticoagulation or antiplatelet, which could not be discontinued. And today at our institute, we any such high risk patients, we give them both options. And when there is an option of low risk, without any surgery, without any anesthesia, obviously they choose for that. And then looking at the results, we had a lot of patients who were not unfit for surgery in that case, where this procedure will be a competitive procedure to TURP. And then they also had significant relief. So we are probably looking at this procedure evolving in future, to be comparable to TURP. But right now, probably we are dealing with high risk patients, and then slowly making that transition towards offering this procedure to almost everybody who is having a BPH. I think we are in that phase where we are transitioning towards the it being a competitive to TURP.
Yeah, that's what I mean. TURP is a well-established procedure as compared to PA, and I mean there's so many literature which has coming recently that it all has proved that PA is, if not superior, it's definitely not inferior to TURP, and its side effect profiles are slightly better than the TURP, particularly in cases of urethral injury or sphincter injury or ejaculatory dysfunction or erectile dysfunction. In that way, PA scores better than TURP. But when you think of that, the objective reduction of the size of the prostate, obviously TRP fares better. It has a better longevity. But PAE still, I think, has a way to go. we have to, with more and more evidence, um, we have to do a lot more follow-ups to say to our patients that that this procedure to stay in this arena, and it is almost as comparable to TURP in dealing with problems. And just one more thing I want to ask you, Dr. Manish, that can we repeat this procedure if the patient does not get benefited? If he feels that that whatever expectations he had prior to undergoing PA is not done, can you repeat it?
Yes. This procedure, as we discussed, it's a young procedure. So probably now there are. It has been 5-6 years since the first procedures underwent, and then now probably is the time when we are seeing those older patients coming back with symptoms, and then there is definitely role for repeating this procedure, because over time either there may be a small collateral supply which we didn't pick up at the time of a first embolization, or the gland has regrown due to presence of collaterals or revascularization. So definitely these patients can be benefited by redoing the procedure. If the patient comes early when they do not have significant relief, we do go back and look at the angiograms. Did we miss any small vessel which was there, and which caused this patient not to have a significant relief? And then sometimes we find there was a small twig or some collateral supply which persisted. So that's where the cone beam CT helps a lot, where once we do the cone beam CT, we are sure that we are covering the entire gland, and there is significantly reduces the chances of these patients coming back early. Then, of course, once 4 years, 5 years later, the literature wise, there is a literature that they may come back in a small percentage, maybe 20%. But then again, this procedure can be easily repeated in those patients, and then they can have a significant relief. As we compare with the TURP again, there also recurrences are known yeah, after TURP, and then either the procedure is redone or considered for other alternate options.
Yeah, wonderful. So definitely we can do a read procedures in PA. So I mean, it was a wonderful discussion to summarize the points that we discussed today. So PA is definitely a uh, uh, new guy in the block, and it has a long way to go. We have to we have to very carefully select our patient for which we can offer prostatic artery embolization. Obviously, uh, it is a very minimally invasive technique that we can offer our patients, which is having an IPSS score of around moderate to severe. It can be done on a daycare procedure. Not in a daycare procedure. I mean, we can just admit the patient, do the procedures, keep them for like 4 to 6 hours, and then we can discharge them. And it has a very good profile. It has a very minimal side effect as compared to its surgical contemporaries. It has a very, I mean, it can be offered to the patients who are not fit for surgery or who are not willing to take the side effect profiles of this surgical procedures, or who are under or due to some medications. So definitely this can be done. Is the cost wise is almost as comparable to TURP as Dr. Manish has mentioned, and at least in India. I don't know about the situation outside India, but the cost wise in India, PAE and TURP will definitely. But if you can see that the surgical cost will probably equivalent to PAE, but the TURP patient has to be in the hospital for a longer period of time, unlike the PAE cases. With PAE, the max we can keep them for 1 day, unless they are catheter dependent. In that case, we have to keep them for 2 or 3 days to give them a catheter trial, and so we can discharge them. So in that way, also financially is slightly more better for the patient, and the risks are very less, and the side effects are very low, and it can definitely, if required, I mean, there's always a small percentage of patient which will come back to you saying that the symptoms has not improved. In that cases, we can take up these cases for a repeat PAE, and not much issue of the um, of the side effects of the radiations. So I think it's a wonderful procedure. It's a good to go, and all interventional radiologists should be definitely taking up this procedure. And I think our urologist colleague and our surgeon's colleague will be happy to give you such cases, where they feel that the patient profile matches with the PAE and inclusion criteria, and who are not fit for this surgical procedures. So we'll be happy to take up any questions.
Thank you so much, first of all, Dr. Manish and Dr. Avinash, for taking us through this very insightful talk today. With your permission, sir, I have a few live questions, if I can please take them up now.
Yeah, please go ahead. Yeah.
Thank you, sir. So, sir, we have received a question here from Dr. Manish, who asks us that from a scientific data point of view, how good is, the comparison between the TURP and the PAE procedure?
As far as I am aware, there has not been a head-to-head trial between TURP and prostate artery embolization, but there have been trial and enough papers between effectiveness of this procedure compared to medication. And then there was a recent trial last year comparing it with a sham procedure, which does show that this procedure produces significant relief. And based on these trials, it is now part of the guidelines. So the NICE guidelines in UK, they recognize TURP, PAE as an option to TURP. So we are going in that direction, and it is finding its scientific hold, and it is being proved to be scientifically effective. So there is no doubt now in that this is a effective procedure and is an option in BPH.
Thank you so much for answering that. I hope that answers the query for Dr. Manish here. Also, sir, another question that we've been asked from Dr. Isha is, although you've touched base upon this element, but I would want you to, re-emphasize, as she has asked, that what is the approximate cost of this particular procedure in India?
So at our institute, the roughly this procedure costs around 1 lakh rupees. Um, uh, um, that's roughly the cost of the procedure. But then again, it depends on the other comorbidities and other things which are used during the procedure. In general, it comes around 1 lakh rupees.
Thank you so much for answering that, sir. Another one, sir, that what is the approximate time we will expect the patient to be on table while a patient is undergoing a PAE?
So roughly the time of the procedure depends on how difficult or how easy to find the arteries are. In my experience, in larger prostates, it's quite easy to find the arteries, and then the procedure takes shorter time, maybe 1 hour to 1.5 hours. When the prostate size is smaller, the arteries are more smaller, and then it takes some time to figure out where the artery is. And then in older patients, the patients who are beyond 80 years, they'll have vessel tortuosity, which makes the procedure more challenging, and then it takes a little more time. So on an average, it may take around 1 hour to 3 hours, depending on the technical difficulty what we face.
If I may add
Right.
on this thing, so I mean, as Dr. Manish was saying, that we use a software in our cath lab system that is called cone beam CT. And if we have this facility, that cone beam CT, we can plan our uh, access route during the cath lab of the procedure, so that we exactly know where we have to go, rather than searching and looking for the smaller, tiny prostatic artery branches from bilateral. So if we do not have this facility in our cath lab, then probably it takes longer. Dr. Manish was saying it may take around up to 2 hours, 2.5 hours. But if we have this access of this facility, probably it shortens our time, it shortens the radiation dose to the patient as well. So it depends upon, and definitely uh, smaller prostate, older patient, lot more tortuous vessels, and much more finer vessels. You have to go all the way to the exact point to give the embolization. So that all depends upon that. So roughly around 1 to 2 hours.
Sure, sir. Thank you for answering that. And I think the last question that I can take up for today's discussion would be, sir, it's a very relevant question that, all these BPH patients would be very much old. So most of the, cases turn up to be older patients. Now, these patients are also having certain renal problems, and I'm sure PAE would be utilizing certain level of contrast. So, sir, is it safe, and what is the approximate amount of, contrast being used in these procedures?
So we do have to use some amount of contrast in these procedures. Again, the amount of contrast can be significantly reduced if we plan the procedure well. So if we have a CT or an MR angiogram which is done up front, so we can evaluate that and look at the probable sites where the prostatic artery is arising. And then secondly is if you have a cone beam CT, definitely that reduces the contrast usage. On an average, the contrast which is used is around 30 cc to around 80 cc, what is used for prostatic artery embolization. It depends on how easy or how difficult the procedure is.
Thank you so much, sir. I think from today's discussion, we have gathered a lot of insightful points about this very novel technique. And I'm sure the audiences, we have received certain, I would want to share, so we have received certain very thank you messages for both of you for taking us through this very informative session. And also on behalf of Teremo and Teremo India Skill Lab, I really wish to thank you, sir, for joining us in delivering this information to all our audiences who have joined us today.
Thank you. Thank you.
Thank you so much. I thank the audiences who have joined us live today. Please stay safe, stay healthy. Thank you, everyone.
Thank you.
Good
Thank you,
night.
sir. Good
Mm.
night, sir. Thank you.